it's up to me to get you back and activated after lunch. So if there are any questions during the presentation, somebody made a remark that they came out of my last presentation was an information overload, so we want to prevent that. Ask questions, please, during the presentation. We've got about an hour, so there should be enough time to handle questions during the presentation and anyone after one as well. So don't hesitate to do that. Let's make it a bit more interactive than this morning. Keeping the balance, improving care whilst managing cost. And I already informed you this morning, my mantra is improved care saves money, if you do it right. So basically what I'm going to do is go a bit deeper into what I told this morning from several perspectives. But first, we need to take a look at what actually has been happening around us in the last 5 to 10 years. The world has completely changed. It's become more instrumented. We're using instruments, and everybody's using instruments all the time. Mobile phones, we're using more medical instruments, we're using all kinds of other instruments, and those instruments are connected. They're interconnected in all kinds of ways. We're talking to medical device suppliers that have medical devices in hospitals around the world and get feedback on the usage of those devices and the problems with those devices on a regular basis, sometimes on an hourly, sometimes on a daily basis, so that they can use those data to, one, improve the next release of those devices, but also to help their customers maintain those devices more smartly. And also in hospitals, devices are interconnected. We do have a lot of devices in hospitals. I had a discussion this morning also on the buildings. There's a lot of sensors in the buildings about temperature, about all kinds of other things that could be that are actually sent into central spots. And it's becoming more intelligent. We need to become more intelligent to use the data. Where with more people, we need information faster, and so it's becoming more intelligent. So there's an explosion of information on the patient. Look at the information on the patient, maybe on his Facebook pages. Or last time I was in Scotland, when was it, on an NHS conference, I saw this platform about patient satisfaction, where people could, a forum where people could put in their opinion about a hospital, and the hospital could actually reply straight away. So there was a two-way interaction. It's a variety of information, all kinds of information. It's from sensors, it's from registrations, it's from lab results, it's from notes from doctors, it's notes from nurses, it's all kinds of information. And the velocity of decision making is increasing all the time. We need to make those decisions faster and faster all the time to basically deliver what kind of people are starting to expect from us. But with that comes a lot of problems. Research by IBM, lack of insight. 1 in 3 managers make decisions, and managers is kind of professionals, make decisions without the information that they really need to make that decision. They just have to guess. They just have to hope, they have to assume. And I was always taught that assume makes an ass of you and me. So I don't like assumptions. Inefficient access. A lot of data are there, but we don't have access to them. And that is a problem across health organizations across the world. Not sure how it is. Do you have easy access to data and information? No. We just had a discussion during lunch as well. Some information is still paper-based. So that's kind of, if you need the information to make your decision, but it's not accessible, how can you actually get at that information? How can you share it? We talked about knowledge sharing this morning as well. How can you share knowledge easily if it is not accessible? And actually predicting what's going to happen. 3 in 4 business leaders say that it would help them do better business. but there's a limited amount that is starting to do it now. And in healthcare, yes, we've been good at building very robust, reliable statistical models based on evidence-based decision-making with our tests and trials. But those are long-term, what I would call strategic models. But we don't have the ability to predict what's going to happen next in our department, on our floor with our individual patient. And that's where we want to go. And we're in a difficult market. Changing demographics and lifestyles. I mean, we had a lot of information this morning. I like the example from the care for the elderly, right? Just basically the changing requirements that a multi-ethnic society brings to healthcare organizations. We're shifting more and more from local to global contexts. One of the things that's happening in mainland Europe is that there is a flow of patients from country to country. A lot of Dutch people, because they don't like waiting lists or they think that the quality is better, they move to Belgium for their healthcare. But we're also getting diseases, right, which kind of started out with traveling ages ago when we started traveling. That disease traveled with us, but now disease is coming to us even faster and other places than we would normally know. Incidence and cost of chronic and re-emerging infectious diseases. Chronic disease, and I'll get to that, and it was also mentioned earlier this morning, is a big issue, and it's costing us a lot of money. And re-emerging infectious diseases, mutations of bacteria and viruses. That are coming at us that we need to keep watching. There's always a shortage of resources, and no matter what we do, we're never going to solve the complete resource problem. The only thing that we can do is trying to make them more productive and efficient, and we need to do that. Patients. Like I said, the example from Scotland, but everywhere, patients are getting more empowered. They expect more of us. They think they know a lot more, right? Well, I found on the internet this, and this. But they also expect better value and quality, and they expect better outcomes. And we need to manage those expectations as well. One of the points made this morning as well. And there's new players with new technologies in healthcare. Not sure, IBM is a very large organization, right? Not sure if you know how big IBM is, but we have worldwide 440,000 employees. A lot of those employees also work in research, and some of them actually medical research. And part of what we're doing is actually nanotechnology for medical purposes, to actually have kind of nanotechnology implanted into cells to fight cancer. If you're interested in that kind of technology, there's an IBM research website, and if you just go to YouTube and type in IBM research, you'll find lots of videos on what we're doing also in the medical field. So there's new technologies and treatments for healthcare. And there are some old treatments that we might have discarded that are coming back, right? My hobby is neuropsychology and the human brain, probably because I want to know why I'm so crazy. Did you know that one of the best things against brain damage from addiction or anything else is mindfulness, meditation? Because it increases the myelin. Buddhist meditation, mindfulness is very good for our brains. So actually old kind of knowledge that we may have discarded comes back, and it does work for us. And some others do not work for us still, but we need to look at, okay, what is coming out, and we need to make progress. These are, since IBM is a global organization, impressive global numbers. I'm not going to go through all of them. But 15% of diagnoses are inaccurate or incomplete, from a Harvard Business Review article in 2010. research. 1 in 10 patients are estimated to be affected by healthcare-related infections in the European Union. That's 10%. That's quite a number. So that actually brings in the average ratio of total healthcare. This is a nice one for people that really know their numbers, right? The average ratio of total healthcare spending to GDP growth in all OECD countries, growing from 7.8% in 2009 to 9%, which basically means that in OECD countries, the spending as a percentage of the gross national product, gross domestic product, is growing by 9% every year. So it's increasing. So what are we going to do it? Well, we call it predictive disease management. And in the background, you see also predicting fraudulent activity in healthcare claims. Yes, I also work on the other side of the medal, at the financial side, working with NHS and other organizations that spend money to actually identify, do we pay somewhere where we shouldn't have paid? But we're going to focus on the front end, predictive disease management. Coming back to the chronic diseases, and again it was mentioned this morning for the UK as well, 60% of all global deaths are caused by chronic diseases. In the US, 75% of their expenditures are for chronic diseases. So chronic diseases, and this is not just the US and could have taken out the European numbers, are very important. And this one we saw already. So how are we going to treat each individual patient in an effective way and an efficient way so that we can actually maybe do a better job? So you need to ask, how am I actually managing my diseases? What is my program? How do I determine specific treatments for individuals? Right? At the moment, it's usually left to the doctors to determine that. And that might mean that the same patient going to 2 different doctors will get 2 different treatment plans. What if you could combine that knowledge? How much of your treatment plan decisions are based on data, or how much of them are educated guesses? I would guess that most of them are educated guesses. Some of them, those guesses are educated based on data. But a lot of them are kind of using our own neural networks, and like I said, there's pros and cons in using our own neural networks. They are very good, and experts tend to be very, very good at identifying patterns, and that's why experienced doctors are pretty good, and others are younger ones still need to learn and need to grow their detection. And then, and I can't remember the article, but there was a research not too long ago that actually the best doctor to go to is a doctor of around 30 years old, because his knowledge from university is up to date enough to be up to speed with what's happening in medicine at the moment, and he is still active enough to keep up with his subject. If they're getting any older, their knowledge gets old, they're not as active in keeping up with their field, and it goes down. And the younger ones just basically do not have the experience yet. So whenever you have something serious, find a doctor of somewhere between 30 and 35. That's the best age category. Sorry? Did I hear? No?
Mutterings from some areas of the audience.
Well, it's. I'll put in my natural disclaimer. It's statistics, so there's always variability, right? And but this is this has been a reasonably good research actually looking at how people were making their decisions.
Perhaps I thought it was 40, but that doesn't help me.
How much reliable these predictions are?
Sorry?
How much correct or how much reliable these predictions are? When a doctor can make a decision.
Yeah.
Depending on these predictions.
Yeah.
So what is the percentage of correction or how much reliable?
The reliability of the predictions, or the accuracy. It really depends on how good your model is. In some cases, right, in scientific research, we tend to do an estimate within 95% reliability, right? So we have a confidence interval around it. What we're looking for in predictive modeling is usually how much can we improve what we're doing. So if I now have a model the way that I'm doing it at the moment and I'm 15% correct, right? If I can increase that by 3%, right? It's not a major, still not a major reliable model because it's still only 18% correct, but I can save a lot of money. So it's more pragmatic. The key there is that you need to have a model that's robust, and especially medical science, right? If you're talking marketing, it doesn't really influence people's lives that much. But if you're talking about medical science, you do need to have a process in place to really look at the robustness and the stability of the model, and is it good enough to be taken into production? So, but you're looking at some other factors than just reliability and accuracy. It's looking at improvements, and I'll get to how it actually fits within current knowledge as well, because you don't throw away what you know, right? It's not like you start all over from scratch. No, you reuse what you know and you build on that. But you're starting to use other areas. So, what can predictive analytics do for you? Reduce cost, allocate resources, I'll get to that. Screen patients, I've given some examples for specific treatments. Predict likelihood of a specific health outcome, right? A key thing in, for example, seat in healthcare in the US, but a lot of other thing is the likelihood of somebody being readmitted within a period of time, right? Major driver, according to publicity, patient satisfaction, real driver, finance, right? Also in the US, hospitals get penalized if they're readmitted too soon after being released from the hospital. So predict the likelihood of outcomes. Effectiveness, risk levels, already discussed that. Risk of recurrence, right? The risk that something is coming back. And I can go on and on. One of the examples that we'll go into also is community safety and disease surveillance, on how you can actually use it for disease surveillance as well. How do you do it? Well, you try to actually optimize the plan by looking at what just happened, why did it happen, to kind of get the structures, and what will happen next, right? If I climb a mountain, right, I can look down on where I've been and how I got where I am, and I can see how I'm holding me now, but then I kind of need a prediction, where can I put my hand best to move forward? Is that rock going to move or not, right? The same with decision making. Do I have something that can point me forward to see where I need to go? And maybe there are multiple options, right? It might be that I see 3 rocks, and then again, that's where the art of medicine comes in, and the knowledge of the doctor, to decide, okay, based on what I know, and it's not in the model, this one should be the best one to go for. So over time, you try to actually get the treatment plans to an optimal level, where you don't have too much treatment, but you also do not have too little treatment. And this is kind of how the process works. You detect and capture data, you analyze and predict, and then you use that to engage with your patient and take action. And that action actually leaves a result that feeds back into your detect and capture, so that you get a learning cycle, a continuous improvement cycle, right? In Japan, they call it Kaizen. First step, you reuse domain expertise, right? Those pathways are not built randomly. They're built with a reason. There is knowledge, there's thinking in there, there's some best practices in there. But within those pathways, you might actually want to refine it. So you take all kinds of data. And now these are maybe the ideal situation. Not all of them may not be available yet, but some of them are, right? Some data are registered in your hospital system, your treatment data. Some of them may not be, but it's kind of okay. This is an ideal picture, and there might actually be more, but the slide would be too full. But you have demographic data about the patient, right? Age, gender, address. You might have information about risk factors on a geographic level that you can match to that, right? You have transaction data. When did they come last? What was the issue? What was the diagnosis? How long ago was it? You've got all kinds of information about the patient. Again, not everything, because you don't have an electronic patient file like they have in some other countries. And then you have external data that might be important. Regional disease info, already mentioned it, weather info, employer info, or maybe job info. And you bring that all together to create segments of patients that are similar. You do time series analysis over time. Do I see trends, and can I look trends over time? You look at certain risk profiles or other profiles, and you can build scoring models. And together with the domain expertise, you bring that together in a scoring environment that kind of brings it together and optimizes decision. Given my model, given my knowledge and my scientific knowledge, I bring it together. I can bring reports and KPIs and KPPs on that, right? Like I said before, I can present, okay, this is what we've done last month. This is what describes our population now, right? The likelihood that they get an infection, the likelihood that they will fall, some of the other examples that I have. And you can actually deploy it to everybody that is relevant within the organization or within the system, right? Maybe to a GP or to others, depending on how it goes with medical privilege. Yeah?
Actually, the biggest field of this is the actual validity, well, is one of them, is the actual validity of the data set. And the data set that you're starting with is the knowledge base that you're starting with is subject to reporting bias and all sorts of things. An example was a publication, the Department of Health's own website, a department publication which indicated in this document, which had analyzed HCAI related to backlog estate maintenance, staffing levels, and they said as measured by, at the time, MRSAC diff rates, there's no correlation at all between them, which many of us would think is counterintuitive, but that's what the outcome came. And that particular study went against the politics of the time, and I think of today, and just disappeared. And I even asked a colleague of mine from Department of Health whether she knew where it was, and she couldn't remember where it was, but it had been archived away. That's an example, maybe one that suits us all, but it's an example of reporting bias.
That is the one. Yeah, that's the one that's something different than what you're talking about is a research report done by somebody that has disappeared. This is more built around creating a model that every time somebody comes in to make a prediction, right? And that the validity of that model is, and that's why it's important when you build a model like that. It's not just a researcher and an IT guy and somebody else, but there needs to be involvement from people from the medical branch, right? The physicians and the clinicians need to be involved in building those models to make sure that it also makes sense. The other thing is that, and again, I'll refer you to Daniel Kahneman on how we handle controversial information. There has been some great research in there, is that people will actually forget the controversial information very quickly and they will put it away. If you really want to also look into that, if you're interested, is Dan Ariely, The Honest Truths About Dishonesty. It just came out, and if you don't want to read the book, look for The Honest Truths About Dishonesty, RSA. There's a great cartoon on YouTube describing kind of the content on how we all lie, especially against ourselves. Yes, every research that is done has all kinds of validity and other issues. And correlations are abused all the time. I can, leave alone the effect of nicotine on the brain, I can prove with a correlation that smoking prevents Alzheimer. And it's very easy to explain, because since less people, the percentage of people that smoke goes down, more percentage of people getting Alzheimer goes up. That's a correlation, right? It's a phony one. So correlation and causation are difficult ones, and the other one is what's called the ecological fallacy, that I would then actually could justify that myself still smoking because my mother had Alzheimer, so I'm at risk, so smoking actually lowers my risk, right? Which basically means I take an aggregate correlation, try to translate it to an individual prediction, and then I'm out of problem. So if there's no correlations on an aggregate level where most of these reports come, doesn't mean that the correlation isn't there on the individual level. There's with those reports, and there's any report that you bring me, I can probably shoot holes in it, right? Because there is no perfection. Right? There's no perfection, and the idea is here is also not to build the perfect model, it's to build a workable model, but reevaluate and monitor the model, right? Keep it. Don't every model, right? The term model itself, right? It's an abstraction of reality. It's not reality itself. So you need to keep it going. And our models about the world change, also about medical science, right? Same here. We change it all the time, we monitor it. That's why you have the feedback loop, to keep it into perspective.
Can I just ask
Yeah?
a question then? What are we talking about for this repository of knowledge
Yeah.
and information? If it's not research-based, what...
It is research-based, but it is different research-based. It's based on looking at patterns in your data set with the objective not to write an article or a report that everybody can read, but it is looking at how can I build a model that is far too difficult to report on, because it might, and then I'll have an example, I think down the line, where you have 400 or 500 inputs to predict something, right? But how can I use that model then, that if another patient comes, to predict what is likely to happen with this patient? So it is research-based, but the outcome is different, right? In traditional research, the result is to write a publication in a medical journal to share with the medical community so that people can learn from it and hopefully they use it in practice, right? In this case, it's also a research project, but it's not based on sampling and scientific research. It's based on the patterns that are in the database of your hospital. To look at, okay, how have we been doing things, what happened in the past, and how can we learn from it, and can we use that, what we've learned, the mistakes that we've made, how can we use that on new patients coming in? That's kind of the difference. Hope that, yeah? California Pacific, I think we have the user story on the stand, which has more information. Basically, how do I get all the data together easily for analysis and for building those models? How can I, one of the first things that they wanted to do, right? They're doing much more now, but these are some of the examples that they do. Predict the risk of developing complications after treatment for coronary diseases. Get better diagnostic tests and diagnostic models. Now, this is what they have a lot of data, and you have a lot of data about your patients, about your treatments, about what happened. You may not have all the data that you may want to have, but you have a starting point, right? When I'm talking to commercial businesses about marketing or fraud detection, right? I said there's always one database that you have that you can start with, because if that database isn't in order, somebody goes to jail. It's their financial administration, right? And you have kind of in the core of your knowledge is in that patient registration, there is information out there. It may not be the best yet, it may not, but part of the project is maybe to improve it and look. And sometimes you need to stop a project because the quality of the data isn't good enough. Facts of life. But it then might kind of gives you the idea, okay, how can we improve that? And that could spin off a different project. What did they do at California Pacific? Better cardiac risk models. Make the treatment faster. Increase the number of people that were treated on income from within 90 minutes to 100%, which was, I think it was something like 50 or 60%. So basically improve the speed of treatment. Just speed up the whole process and therefore getting 8% reduction in patient mortality, which is pretty good. Also some complications were prevented, right? Multivessel coronary disease and diabetical surgical patients, but overall shorten the length of stay and reducing costs. So they improved the quality of their service, of their healthcare delivery, while saving cost. Santa Barbara is in Spain, again on diagnosis, and they basically developed a diagnosis model for DVT, and they reduced the colon cancer cost by basically getting a better diagnosis and better targeting their testing, similar to the one in Italy, right? Making sure that you only perform the tests that you have to do. Why? It saves money, it's better for the patient, and you can get to an earlier result instead of going through the standard list to check all the boxes that you followed procedure. So that there are some others. Also, this story is available. Going back a level higher to medical research, similar techniques are being used in medical research to go further than just the traditional statistical models and analysis of variance in all kinds of ways. In some cases, you need to do it, right? If we're talking about DNA data, genetic data, and all kinds of, the amount of data is just immense. So you do need something that will help you identify those patterns and those things. Georgia basically is developing models for on childhood diabetes, asthma, and autism, and then basically sharing that with the world and trying to develop new protocols and new frameworks and things like that that can then be used by everybody across the world. So the technology can be used both from a scientific long-term perspective down to an operational perspective. I just want to go in a bit deeper still on what I discussed this morning. Some of the data that we've seen used and makes sense. The quality of life data, so patient satisfaction, quality of life, long-term quality of life, patient data, already discussed those. Clinical trials maybe that you may have going on in your hospital, to take the clinical trial information, and then epidemiological factors that have an influence. You analyze that. I didn't put in the business knowledge now, but you score that and you can actually generate treatment recommendations. And you can also then score and send reports to public health policy and initiatives to see, okay, what's going on, what are the risks that we're running, what is going on. Who are the people doing this? Research institutes. So the example that I used from the Netherlands used to be a research department of a hospital. They privatized and they're now a research institute. They basically, right, look at a lot of data, difficult getting access to those data, and then trying to actually improve the decision making by looking at all the correlations and trends, right? And look at, again, there is a clear research component in it to come back, and you do need to know what you're talking about, right? Or else you'll get you might actually be making. Sometimes it's not bad to make decisions based on spurious correlations if the impact isn't that big. but in medical science, it's still kind of a no-no, right? You know, the most famous spurious correlation is the correlation between the number of storks and the number of children that are being born. I think it was Denmark or Germany. You know, that if the storks go, the number of storks go down, the number of babies being born go down. Prove that the stork brings the babies. Right? Which was actually after the war, and it basically had to do with urbanization. The number of storks went out because there were more buildings built, and in cities people get fewer babies. So that is not a correlation that you would send out right. If you see a stork, you don't send out somebody from the maternity ward or whatever. But on the other hand, a business might use that because they're not interested in it, but a correlation is causation. They just want to use it because it can improve their marketing, right? And the effect is a bit less. So you do need to look at the thing. It can be very well used and to look at patient care problems, right? Misdiagnosis, where did we go wrong? Error modeling, as we call it, or prescription errors. But it can also be used to look at maybe things that you didn't know for early identification. The example that I just used about the undernourishment, right? If you can earlier identify it, can we earlier identify a problem? Maybe we don't solve the problem, but if we can identify it earlier, we can put in a solution in place, which in this case was adding food supplements. And I already said that you need a strict test procedure and a validation procedure before you take it into production in clinics. An example, Centerstone. Basically, they are a research institute, and I think we also have it with us. But they model data from all kinds of patient experiences, clinical outcomes, and all kinds of other sources. And what they're basically doing is using that to lower operating cost and to yield a 50% improvement in choosing the correct treatment, right? So improving the choices made by physicians by just generating the right options for them. Clinicians. You're all clinicians, I think, right? Or most of you. You want to know that you make a decision that's based on fact, right? But the facts are hidden in all kinds of data sources. There's large data, they're difficult to access, we already discussed that. And it takes a long time to get the insights from the data, right? Sometimes, again, project in the Netherlands, because I'm working at the moment on a project that involves 6 hospitals. They had been working on a project for about a year to find all kinds of interactions and things like that, by very painfully doing it the traditional way and using kind of modern technology. We did the same in 2 hours. Kind of seeing, okay, if you're looking at it, you do need to look at modern technology if this is one of the things that you come by. The other thing is that because it's so difficult to get the insights, we tend to still work a lot with averages. And only average companies use averages, right? An average is always wrong. Rule number 1 from statistics. Nobody is average. And the other thing is that if you take an average, you need to make sure that you have a homogeneous population to determine it on. Just the example that we had before lunch, that if you're 70 and you're a male, you're likely to live on average for 17 years, right? Means that the probability that you're going to die before you're 87 is much larger. Because it's a skewed distribution. So an average there doesn't make sense. And one of the things, right, that we do a lot in staff planning and other things is we use with averages, and we're using the wrong averages because there are all kinds of different populations in there. So how can we use that? Using analytics to identify root causes, and I need to watch my time, I'm just aware of, combine data, modeling, and then shorten, for example, lengths of stays and all the other things that we talked about. Sequoia in the USA, another example of a company that, or a hospital that really picked it up. Just an example, they reshaped its protocols and cut its mortality rates from 2.9 to 1.3%. And there are some other values in there as well. Right? Public health organizations. How can we better surveillance diseases? How can we maybe earlier detect something that's going on? So can we look at maybe better planning our emergency interactions? Can we maybe limit it? Right? One of the things that we do in the US is with CDC. They use our technology to early identify risk points and very quickly interact with people in the field, not to wait for everything to go through the system, but focus their requirements too early and then do very quick analysis so that they can try and minimize the outbreak of an infectious disease. A regional health department in the US, basically they wanted to look at elevated levels and changes in levels and anomalies in syndromes by looking at daily data from the emergency rooms and all the clinical data from all the hospitals, and then basically using statistics and other analytics to detect changes in trends and patterns, to email alerts to the relevant people. And then the standard reports were also available, but make sure that people were alerted. By automating it and actually making it more accessible and making it easier as well for the providers, so that they don't need to send out their reports all the time, but automating the whole process. In a city, kind of similar, but looking at other set of data, because the region kind of looks more overall, and the city in the US is more the first responder, so they needed to be a bit more proactive. So they wanted to actually improve their reaction times by monitoring, again, changes in patterns and levels of certain things. So they were looking at data from calls to the medics, over-the-counter sales for flu remedies, school attendance, animal death, ambulance runs, all kinds of data that they used, and they were actually looking, okay, is this within what we would expect, or do we see a deviation, and do we need to jump in on this? And do we need to identify, might we have a problem arising? Last, operations and resource needs. We need to be visible and flexible, because we have a pressure on cost, we need to have speed, we need to be flexible, and we need to deliver quality. And then we need to work with people, capital, and processes. That's kind of it. And we need to be agile. We need to go from long-term planning, right, to being agile to new developments that are coming up. That doesn't mean that long-term planning is dead, but we don't want to make long-term plans too detailed because we want to change in between. Because we never know if there's going to be a disease outbreak. We never know if there's going to be a flu epidemic and suddenly 50% of our nurses are ill. Right? We don't know if there's going to be a flood somewhere or a large criminal or terrorist incident. So we need to be agile in what's going to happen. And we need to do that through our whole cycle of operational performance. And hospitals are special. There's no other business that compares to hospitals. I haven't found it. If somebody can give me an example that is exactly the same. Your patients are admitted in fluctuating numbers, and it really depends on injury, illness, right, accidents, anything that helps. You're open 24 hours a day, 7 days a week, 365 or 366 days a year. And then you have your staff that you need to schedule. It's usually by shift or by hour or on call. And you need to balance the scheduling, right? Short staffing causes delays and increased dissatisfaction. Excess staff costs money, and oh, by the way, people do want to have their days off, and they do want to have their weekends off, and they do have families, and they do have a life outside of the hospital. And I already mentioned the medical devices as an example, right? They're either occupied or they're used, so they're also, and I can kind of bring the whole list down. So how do you get to smarter hospital operations? One is talk to your patients, listen to your patients. Listen to the patients, what they're saying, what they've experienced, and learn from it, right? Maybe not very long questionnaires, maybe just 3 questions. What did we do good? What did we do well? What could we have done better? And what do you expect of us in the future? Might just be the 3 questions that you want to ask your patients. Talk to the people on the floor. Involve them on the floor. Make sure that you're not sitting in an ivory tower, but actually listen to and get feedback models from the people in the floor. What is happening? What does work? What doesn't work? Get feedback. Collect information, and incorporate that with the data from the hospital, right? And there's, depending on subject, HR data, right? If you're, for example, talking about predicting absenteeism or burnouts, or managing absenteeism, patient records, all kinds of other data, and use the experience. One of the great examples, things that were mentioned this morning, the quality of management is important. Right? And that goes in every industry. One of the biggest problems in the retail industry is shrinkage, which is basically goods that have been bought but cannot be sold because they have to be destroyed or they're stolen or they disappear or whatever. Right? And every retail shop you go into is the quality of the manager, the way he manages his people and how he manages his processes determines whether that shop has a high or a low shrinkage. Management on the shop floor or on the hospital floor is important. Atmosphere in a department, within a team, is important, but it can also be dangerous. One of the things that I've discovered, and it's been confirmed by others in stress and absenteeism, is if you have a department that is working too closely, too good together, they're good friends, and there's a lot of synergy, you will get the problem of presenteeism. People will get back to work too early. And actually your sickness, your absenteeism will increase, but you will have a different pattern. Instead of people being sick for longer times, they will be sick more often for shorter times because they don't want to burden their colleagues, their friends with the extra work if they're gone, right? So good management also means managing that. But having good management and good knowledge about what's going on in the hospital, which also means that it's not just the business manager, it's also the people with knowledge about what happens in the clinic. The clinicians are important. And then make your models and provide insight on all kinds of ways. I'll skip this one. Because I need to look at my time. I'll just go to the case studies. France. Centre Hospitalier de Niort, basically predicting the activities that were coming their way so that they could better schedule and plan what was going ahead. The whole idea is that if we can anticipate what's coming our way, we can better organize. If we know how many people or how many treatments or what we have, then we can better organize our schedule. And not doing it on using the averages, but using kind of a more advanced model where we've segmented the whole population into the different areas that we have, because then we can be more accurate and more precise. Same for a Dutch hospital. And actually then also deploying it into different other models. I will not go into it. But basically predict the duration of treatment the moment that people come in and update that based on new incoming data while people are being treated, right? But if you know beforehand, if this person is coming in, he will probably occupy this bed for 6 days, right? that will gives you an advantage, because then you already have kind of an indicator on how I can treat it if I have it for all my patients. So you basically can determine your staff requirements, all kinds of other requirements. If you know that if a person comes in, that he's probably going to need an X-ray and that he's going to need a plaster or later on, right? Or the likelihood of that, then you can actually kind of warn those departments that this person is coming their way shortly, so that they can actually work that into the planning of today. And that way you can anticipate what's coming. So with that, I want to thank you. It was new to me that the presentations were going to be sent out, or else I would say leave your name, number, details, serial number, everything at our stand, and we can send it to you, but apparently they're already being sent out. If you want more information, again, we have some of the materials with us. There's more materials on our website. There's a whole UK healthcare portal for this subject. Look at YouTube at IBM Watson or IBM Research, and there's a wealth of material out there.
Yeah,
Thank you.
very much.